Thank you all so much. And so the title of this talk is In-Utero Therapies to Cure Cleft Palate. We are hopefully paving the way in our laboratory. And this is kind of the purpose of my PhD training. And so this is like my topic of immense interest, which is cleft lip and palate, which I alluded to earlier. So let me just tell you how it happens. With the palate, normally it should form during pretty early weeks in gestation. So this is first trimester of gestation, right? And so by weeks 4 and 5, we see these palatal shelves. Those are like two ends of the palate. So this is the tongue in the middle. It's like we're looking straight on into someone's oral cavity, So we have the tongue on the bottom, and then the palate is going to be forming from these shelves that grow down, and then they come toward the middle, and then they fuse with the nose. And then you get this barrier between the oral cavity and the nasal cavity. And so that barrier is really important because it allows you to be able to chew food. It allows you to swallow. It allows you to speak and make like consonant sounds like k, k. That's because your palate isn't clefted. And so it's like a very, very essential structure in your body. And people don't necessarily recognize it, I think. And there's a whole spectrum of severity of these diseases. You can have just the palate that has a gap in it from a cleft, or you can see a cleft that goes all the way through the lip, as well as you see in some of those pictures that you maybe have seen on the internet, where the babies are pretty severely affected. And this can happen from a number of different causes, but some of them are specific genes, as I mentioned, or maybe there was a toxic exposure of the embryo while it was developing. Maybe it was exposed to tobacco smoke, or it was exposed to alcohol, or other teratogens, they're called. They're little molecules that can wreak havoc on developing fetuses. And so there's a lot of different causes and a lot of different severities, but there is an interesting evolution in the field, because we see that patients have this lifelong journey. I mean, you are born with a cleft lip or a cleft palate, and at about 3 months old, you're going to get your lip repaired. And then when you're 9 to 18 months old, you'll have the palate repaired. So it's at all these different stages. At years 5 to 7, they do this surgery at the back of your throat to correct the muscles that can make that consonant sound when you're speaking. It helps you swallow as well. It's called velopharyngeal insufficiency. And then when you're 7 to 12 years old, you get a bone graft in your mouth that allows that space in the palate to be filled with some hard tissue. And then finally, when you're a teenager or you're a young adult, you might need surgery where you actually make a cut on the face of the bone of the face right there, the maxilla, and you advance it forward. And you allow your face to have normal symmetry and your teeth to come together properly to occlude. And so this is a lifelong journey, as you can imagine. I mean, this is not just like a one surgery and you're done and you're good. And there's an estimated cost to each patient of about $200,000 when you're born with a cleft lip or palate. I mean, it's insane how much this costs. And so every year in the United States alone, we're spending over $1 billion on these procedures and all the care that goes into having a cleft lip or a cleft palate. And this is just a study from a journal that showed that over half, almost 2/3 of patients that have a cleft palate, they need this like massive bony reconstruction procedure called a Lefort osteotomy, where you advance that maxillary bone forward. And so obviously the current gold standard, or the standard of care, is not really that golden. That's what I mean in that title. It's not really working the way that it probably should. And so now, do you believe me? Do you believe me that there's a problem? If not, let me show you some stuff here. So we can use tools in our arsenal right now. You've probably heard about the field of regenerative medicine and tissue engineering. So this is really a field that takes 3 different things all together. They take cells from a patient's body. They take molecules that help cells differentiate and turn into different types of cells. And then they take scaffolds, or these like structures that you can place inside the body, and you put them all together, and then you can hopefully reconstruct parts of the body that aren't formed properly. So this is like regenerative medicine 101. And we have written about ways that we can use regenerative medicine, like a patient's own stem cells, to induce regenerative bone in the patient's face, because the face has like all this skeletal structure, right? And sometimes you have like specific diseases like cancer where you have to take away the bone, or like you get in an accident and you break some of the bone, or you're born with a cleft palate and you don't have that bone there. And so we can use all these sorts of regenerative medicine techniques to approach it. And hopefully we could have some better, surgical and treatment outcomes, right? After doing all of that. This is something that we've written about, is kind of making it very patient specific too. As I mentioned, all of these cleft lips and cleft palates, they're very unique to each patient. And so it doesn't really, there's not like a one size fits all solution. You can't just like throw a scaffold in there and throw some stem cells in there and then hope that the bone grows. It has to fit the defect perfectly. So I saw that there was a seminar given by one of the delegates on the schedule about 3D printing and like modeling to different structures. And so that's exactly what we do for cleft palate as well. It's starting to become much more common, where we would 3D print a scaffold that's the exact shape of the cleft in the patient's mouth. And then we could seed it. We could place some stem cells or some growth factors of different types on that three-dimensional scaffold and then place it in the patient. And then we can correct the form of the palate, and the patient can, regain their function, having an intact palate. So it's a very promising way to approach the problem after it's occurred. If you have a cleft palate, then you can approach it surgically like that. So that's one way you could approach it. But, I mentioned to you that, what if we could totally change the field, right? What if we could identify that there is a cleft lip or a cleft palate while the baby is still teeny tiny, still first trimester, while, mom is just kind of recently pregnant. And we have seen studies recently that have shown that we have high frequency ultrasound machines, like very, very high resolution imaging, that can show the cleft as early as 6 to 7 weeks old in utero. So that's tiny, tiny little embryo, but you can see the cleft. And we can even do specific DNA and RNA studies, take some of mother's blood. And something interesting is that the fetal blood from the placenta is constantly crossing with the mother's blood. And so you get something called cell-free DNA that comes from the fetus and can be actually identified from the mother's blood sample. And so you can take mom's blood, and then you can use these genomic measures to identify different chromosomes and different deletions, different mutations in the fetus's DNA. And so we can identify it maybe even earlier than 6 to 7 weeks. And so what could really change the field, what we think, is if we could identify a cleft lip or cleft palate in a baby from very early on, then we could identify the specific gene. And if we understand the gene and its pathway, the molecules that contribute to that genetic pathway, what if we could intervene with an in utero therapy rather than waiting when the baby's born and like we have to do all these scaffolds and stem cells and stuff and try to regenerate the bone? What if we could salvage the pathway while the baby's developing before it's too late? That's like the dream. And so this is kind of the model that we have developed and devised through our research, is identifying specific signaling pathways. I know this is a lot of like mumbo jumbo here on the screen, but this is essentially one pathway called the WNT, W-N-T signaling pathway, that contributes to development of embryos. And specifically WNT, it's involved in all sorts of organs in the body, but it plays a really unique role in bone tissue. And so when you have not enough WNT signaling going on in the body, your bone atrophies. It doesn't grow properly. So you see, decreased WNT signaling in osteoporosis when there's a bunch of holes in the bone, and you see decreased WNT signaling, we have shown and others have shown, when there's a cleft palate. And so what if we could deliver a drug that could increase WNT signaling when there's a gene mutation there that's causing a cleft palate and there's low WNT signaling? And we have shown through some preliminary data that if you can intervene when the baby is in utero in a mouse model, you can actually correct the cleft palate defect, and the palate can be completely fused after a single treatment while the embryo is developing. It's pretty cool technology. It's like very, very basic science, and it's identifying that pathway, that signaling pathway, and treating that pathway for a specific clinical outcome. So this is a great way to see, something go from basic concept, basic science at the bench, and moving towards, bench side, where we could potentially translate it into patient care. That's the ultimate goal. And this was really inspired by translational research success in patient care. There is a group out in Europe that actually used the same exact treatment technique for a different pathway. It was ectodisplacin signaling pathway, but they did the same thing. They used a single injection of a drug that increased signaling during development of for these babies, and they did it in 2 twin boys that had this disease, this X-linked disease, and these boys were cured after the single dose treatment. And so after seeing this, we had a lot of optimism, that our treatment in our animal model could, in fact, advance to the next stage in patient care, because we're seeing that it's already being applied to other diseases that are actually less prevalent than cleft palate. Cleft palate is a pretty prevalent worldwide disease. There's tens of thousands of cases every year all over the world, and this is a very rare disease. And so if this is working for a very rare disease, what if we could get this same technique to work for a much more common disease all over the world? There'd be huge global health implications. And so we have already modeled and demonstrated success with this therapy in our cleft palate model. We show, a normal palate should look like this. This is a mouse model here. And then this is a cleft palate when there's decreased Wnt signaling. But then if we treat that cleft palate with single dose therapy, then we can see that the treated palate looks a whole lot like the regular palate. It's not perfect, but it's closed. And that's like what they need in order for them to survive and for them to have a normal life moving forward. And so this is kind of the idea. And right now we're in the phase of optimizing that treatment protocol. We'd like to be able to get it to the point where it's effective and it's safe for these embryos, because you obviously don't want to do anything that could injure the embryo while it's developing. That's a huge concern, right? Anything that you do in utero, there's going to be a lot of pushback from the FDA, from people who are rightfully so, they want to protect any risk of treating an embryo too early, and maybe you're exposing them to a toxic level of this drug, because drugs are chemicals at the end of the day. But this is something that we are working very closely on, of optimizing the dose and the timing of the injection, so that we can just do a single time, so that we're not overdoing the dose, and we're optimizing the safety and the efficacy. So we're allowing for the palate to be fused once the baby is born. And now we're at kind of an exciting time. So Abigail asked, how do you test the treatment? So good. Yeah. So the main test for these treatments is that the palate looks like this. So this is, I should have explained this staining. So this is an H&E stain right here in the middle. So basically it just lights up different cells on the tissue in different colors, so you can see, where they are in space. But this is the normal palate without the gene mutation. So this palate didn't receive a treatment. It developed properly. So this is the bridge between the nasal cavity and the oral cavity that we were talking about. But when there's a gene mutation there that decreases the Wnt signaling, then we get this cleft palate, which has this gap right here. So we have this communication between the nasal cavity and the oral cavity. So that's not good. And so with the same genotype, this also has the same gene mutation. We treated this one and this one right here with a single dose of that treatment. And then you can see that the palate is fused very similarly to what the normal or the wild type animal had without the treatment. And so that's like the main outcome of how we test the efficacy of the treatment. And obviously the other way to test how it worked was to make sure that the embryos don't die. I mean, that's like that would be the worst case scenario. Obviously, if you overdo the treatment, then maybe, there was too much toxic exposure and the embryo couldn't survive all the way to birth. And so that's like what we're trying to avoid by doing these next round of optimization studies, showing that there's a specific time window where we should be injecting, like not too early and not too late, but just right. And there's an optimal dose range of volume and dosage. And so that's a large part of what my PhD is doing right now. And the other part of what I'm doing is using these kind of next generation sequencing techniques, which I don't know if you guys have heard much about multi-omics, but basically omics is like this huge catchphrase that encompasses studying all these different parts of what makes up our entire body. So the genome is like DNA structure, double helix DNA, deoxyribonucleic acid. That's what that is about. Epigenome or epigenetics are all of the factors that are like connected to the DNA. It's like epi means like around, so around the genome. And so when you study epigenomics, you're looking at like the histones that the DNA is wrapped around, and you're looking at some of the methylation sites that come and they methylate the DNA and then they cause it to be turned on or turned off. And then transcriptomics, this is one of particular interest for me because the transcriptome shows you gene expression. And so I've talked a lot about, sometimes when there's a gene that is mutated, then you get a cleft palate, for example. So I look a lot at the transcriptome with my studies because we're looking at RNA and the way that and then proteome goes on to the protein. So you have the transcriptome with RNA, right? It's like the molecular dogma of biology goes from DNA to RNA to protein. So that's exactly what this is: DNA, RNA, protein. And then metabolomics is like even further down the pathway. You're looking at like enzymes and different byproducts and all these different things. But these right here are kind of my area of expertise right now, is transcriptomics and proteomics, because those are the things that affect the processes inside the human body, right? If you have a gene that's being expressed actively, then it's being transcribed into RNA. And then that RNA will be translated into protein a lot of the time. And then it's that protein that actually goes and does stuff in your body, right? So like understanding these two can tell you a whole lot about, what is healthy and then what is a disease state. And so that's really the future of where this field is going. You'll read in a lot of papers if you follow Nature or science journals. A lot of the papers that come out are about these topics, genomics, transcriptomics, proteomics. That's like omics is the big thing. So that's a lot of what my PhD is doing right now. If you're interested in that at all, you can let me know.